welcome to Stéphane Doyon and Elizabeth Ledger, who are going to be the moderator. Thank you very much, Claudia. We're going indeed to moderate this session on malnutrition. I'm Stéphane Doyon, involved with MSF, more particularly with regard to access to medical products. Now, nutrition is a major issue. We have to deal with a lot of children in crisis. We deal with a lot of progress has been made in the past 20 years. Some 20 years ago, only 100,000 children were taken care of with specialized products. There were 9 million last year, according to UNICEF. And this was possible thanks to decentralization of care and the use of RUTF, what we call Plan Pinot. Unfortunately, very few studies have been looking into this. And so we're going to hear about this today. Two subjects on the agenda, Kwashiorkor. In fact, we don't know a lot about the etiology, and there are going to be two studies and two presentations on this issue, and the other one on the protocol, management protocols for malnutrition. This was based in the initial protocols were originated in the 1970s, but with very limited medical evidence to inform the management protocols, and this gave rise to controversies. And one of the studies we're going to hear about is on this subject in particular.
And pass the mic to Elizabeth. Thank you.
Thank you. So hello, my name's Liz Ledger. For those of you who I've not met, I'm one of the pediatric advisors for MSF France. And it's my great pleasure to introduce the first study in this malnutrition session. It's long been a belief and understanding that children with severe malnutrition are particularly sensitive and vulnerable to fluid overload. That giving IV fluid to children with severe acute malnutrition can potentially harm them. This next study is a great example of how questions from the field, along with a lack of evidence currently, and collaboration between MSF on an intersectional platform and an external academic institution can lead to a really high quality clinical trial with some very exciting results that we're going to hear. So I'd like to introduce Roisin Connon, who is a statistician with the MRC Clinical Trials Unit at University College London, and Dr. Kemi Ogundipe, who is one of my pediatric advisor colleagues from MSF Belgium. She is a source of great wisdom and advice on the pediatric platform, and there are many weeks that go by when I think, what would Kemi do when I get an email in my inbox? So without further ado, I'll hand over to Kemi and Roisin to talk about the GastroSam study.
Thank you. We're excited to present about this study today. But one thing before we go into the presentation, we wanted to highlight that the study is going to be published in an article next week. So we ask you during this next week, please do not publish the results. They're meant to be presented here in this forum, but they're not to be shared or put into the public before the release of the article. With that, I'll go ahead and get started. So we're going to talk about rehydration of children with severe acute malnutrition. So as Lizzie already began to talk about, gastroenteritis, vomiting and diarrhea is commonly seen in children with severe acute malnutrition, also known as SAM. And it's often associated with very poor outcomes, with these children often going on to develop severe dehydration, and a lot of them having a high mortality as high as 21%. It's been historically challenging to rehydrate these children because they believe that children with malnutrition and gastroenteritis, due to their fragility, cannot tolerate getting IV fluids. The main concern is that if we give them IV fluids, historically, that their hearts would not be able to tolerate that, and they would go into heart failure. There was also concerns about them being able to manage electrolytes or have very big switches in their electrolyte balance while they're dehydrated. They're also often very sick, so that complicates their management. So recommendations on their management has typically been very conservative. They often differ from what we say for children without malnutrition. Specifically, they are restrictive of IV fluids, saying that they should not be given to children who have severe acute malnutrition and dehydration. rather to use oral rehydration to rehydrate them. And these recommendations have been based on expert opinion, based on these concerns that I already mentioned. The concern for electrolyte derangements has also come through in the recommendations that we have for children with severe acute malnutrition, and has led to the fabrication of Risomal, which is a rehydration solution, oral rehydration solution for the children with malnutrition. And that's given instead of the standard WHO ORS solution, with the goal to avoid electrolyte problems. Risomal specifically has lower sodium and potassium than standard ORS. So the GASTROSAM study that we're presenting today is trying to investigate this particular problem, how to best rehydrate children with malnutrition. We have previous reassuring data on the cardiac function in children with severe acute malnutrition. So now we wanted to investigate whether IV fluids can be safely given for rehydration for children with severe malnutrition and severe dehydration, and whether the standard ORS, which we've avoided in the past in lieu of the Risomal, can be given also safely. We hypothesized in our study that the liberal rehydration strategies, meaning us giving IV fluids for severe dehydration and using ORS as compared to Risomal, may reduce adverse outcomes related to mortality and morbidity, and may improve time to recovery of children with severe acute malnutrition.
Okay, moving on to the design of the trial. We recruited children with SAM and diarrhea aged 6 months to 12 years with either severe or moderate dehydration. So those with severe dehydration were randomized to one of 3 different rehydration strategies. So we had the control arm, which is the current standard of care, where they get a bolus if they're in shock and no other IV rehydration. So the gray boxes are showing the treatments if they're in shock, and then the white boxes are what they get after treatment for shock or if they're not in shock. So that's our control arm. And then we had our 2 strategies that we're calling the liberal strategies, where they do receive IV rehydration. So one of these is Plan C, which is the standard of care for children that don't have SAM. And then we also had a slower IV rehydration strategy. And our main comparison was comparing the control to both of these strategies combined. So then we had a randomization between the 2 types of oral rehydration, the Risomal or the standard ORS, and this comparison included both the severe and some dehydration groups. Our primary outcomes were mortality at 96 hours for the IV rehydration comparison, and for the oral rehydration, it was change in sodium at 24 hours. And the sample size was to give us 80% power, assuming that we had 58% mortality in the control arm, and there was a 30% relative reduction in the liberal arms. And for our outcome of change in sodium, we had more than 90% power to detect a difference of 3 millimoles. This map is showing our trial sites. So we had sites in Kilifi and Coast General in Kenya, Mbale and Soroti in Uganda, and then we had the 2 MSF sites, Magaria and Maiduguri. We recruited 415 children in total, which was 272 that were severely dehydrated and 143 with some dehydration. So all 415 were included in the comparison of the Risomal versus ORS. And we'll present results for each of those comparisons separately. And this is a graph of recruitment. So the trial started back in 2019, recruited a few patients, and then there was a long stoppage during the COVID pandemic. And then recruitment did reopen, but quite slowly until MSF joined the trial, and back at the end of 2023, beginning of 2024, and then we managed to complete recruitment and meet our target.
So just to describe a little bit of the baseline characteristics of the children who were enrolled in the study. From here on, we'll be comparing children who are in the standard of care WHO SAM arm to the children who received IV fluids who are in the liberal arms of the study. So these are not all the baseline characteristics, but I wanted to highlight a few key ones that might be interesting going forward. The first one is that the population that we had in the study were mostly young, with a median age of the children at 13 months, so a lot of them were below 2 years old. You can also notice that a lot of them were very sick, with them having signs that showed there were circulatory impairment or problems with circulation, so weak pulse, some with hypotension, capillary refill, and prolonged tachycardia. You can also see, as we expected, that there were electrolyte derangements, specifically low sodium, with about 50% of the children we saw having that as one of the findings at baseline when they were enrolled in the study. So to highlight a little bit of the clinical management during the study, the first thing I wanted to point out was that there was very good adherence in the study teams to the protocol that was put to them, meaning that if there was a child who was meant to receive IV fluids, they received it. It was just under 100% of the children who were randomized received fluids according to how they were randomized. We also saw about 10% of the patients presenting with shock at admission, and they were treated according to the arm of the study, in those gray boxes that we showed. And they received boluses or received IV fluids depending on what that protocol, what the arm of the study dictated for them. Another thing to highlight is that for the WHO-SAM arm, where they're not meant to receive IV fluids at admission, we noted that about 13% of them went on to require and receive IV fluids in the first 24 hours after their initial evaluation and management. This was typically because they developed shock after the initial few hours, or some other severe adverse event that required them to be treated with IV fluids. Also, I wanted to highlight that in the WHO-SAM arm, there were way more patients who required NG tubes to be placed to rehydrate them orally versus in the liberal arms of the study. There was also a lot more vomiting in the WHO-SAM arm as compared to the liberal arms of the study.
Okay, so moving on to our primary outcome. This is for the comparison of the liberal versus standard of care rehydration in the severely dehydrated children. And all analyses in this trial followed intention to treat principle. So overall mortality in this severely dehydrated group was around 7% at 96 hours. So we had 11 deaths in the control arm and 9 in the liberal arms. And the adjusted risk ratio was 1.02. This is adjusted for site, but we had a wide confidence interval. So we were aiming to show that the liberal strategies were superior, and we found that there was no difference, although because the overall mortality was much lower than we had assumed, the power to detect a difference was quite low. And at 28 days, we had overall mortality of 11%, and again, this wasn't a significant difference between the arms. And the graph here is showing mortality to 28 days over time.
Looking further at the results, the other thing we looked at very closely was were the outcomes linked to heart failure, so pulmonary edema and signs of heart failure. And we looked at those very closely because that was the major concern and the reason why previous guidelines have been restrictive. And when we looked at that across all the arms, we found that there were no reports of signs of pulmonary edema or other signs of heart failure across any of the arms throughout the study. We also looked at the other severe adverse events, and we didn't see any difference in any of the in the rate of severe adverse events across the arms, which shows that there was no extra hidden arms in any of the arms of the study that we looked at. When we also looked at the electrolytes, we did note that for this severe dehydration part, there was a difference in the change in sodium and potassium among the rehydration arms. Specifically, at the 8-hour mark, there was sodium corrected faster for the children who were given IV fluids versus in the WHO-SAM arm. But this we'll see later on ends up becoming minimal after 24 hours after continued rehydration with oral solutions. So in looking at the severe rehydration part of the study, in comparing the rehydration strategies, liberal with IV fluids versus standard of care, we did not see any evidence of difference in mortality among the different groups that were receiving different rehydration strategies. Of course, as Roshin mentioned, the overall mortality was much less than we anticipated, and that was predicted from literature, which was different than our hypothesis. This is a limitation of the study, though it's good for our patients. This difference is probably associated with the study environment itself that we were working in, where there was, for the study period, closer monitoring, dedicated staff to care for the patients, and us actively searching for the complications among the patients who were recruited to the study during this period. This is a lesson in and of itself that requires further reflection. Also, I wanted to highlight that in searching for these other potential risks and harms, especially the ones related to fluid overload and heart failure, we didn't see any difference in severe adverse events between the arms, nor did we see the thing we feared the most, fluid overload events, across any of the patients who were in the study.
So now looking at the comparison of the two oral rehydration solutions, the RISOMAL versus ORS, and our primary outcome was change in sodium. And we had good completeness of the sodium for this primary outcome. And in both arms, at 24 hours, sodium had increased by approximately 5 millimoles, and there was no evidence of a difference between the arms. And at 28 days, we had a mortality of 10%. Again, no evidence of a difference. Oh, and there was no further evidence of pulmonary edema or heart failure in this bigger group either. So in conclusion, for the oral rehydration, there was no evidence of a difference in change in sodium at 24 hours, but there were also no safety concerns from using the standard ORS in this population.
So, taking both the IV rehydration and oral rehydration parts of the study together, what can we conclude? First, though, the first thing we can say is that while there was no difference in mortality between the groups due to the low number of mortality events, we can see that there is no evidence of harm with giving IV fluids for rehydration for children with severe acute malnutrition and severe dehydration, nor is there evidence of harm with using standard ORS solutions instead of RISOMAL for children with moderate dehydration. These findings for us are pretty important in getting more insight into how we continue to care for these populations, especially in the context where MSF works, and they can hopefully inform our future guidelines, including ways for us to simplify the rehydration protocols between malnourished and non-malnourished patients specifically. We also saw very good adherence to the research protocol, which I would like to highlight as an amazing achievement, especially for the MSF Magare and Maiduguri teams who are conducting a randomized control trial for the very first time, and in situations that were often challenging with the peak season, floods, protests, and they did this with the highest quality and did this with some of the sickest patients. Of course, this study is adding to a body of evidence that we already mentioned is very little, and is a key addition to this limited body of evidence, and we are glad that we have played a part in doing that too. So I'll end by saying that this study was a big effort across many actors, and it was huge, and we are from different organizations presenting today just to illustrate that. So we want to thank all of the people who were involved and acknowledge them, especially the patients and their families.
Thank you, Kemi and Roisin. Lots of things to talk about there. Please do keep your questions for the end. The thing that really stands out for me, though, is the importance of high-quality nursing. I'll pass on to Stefan now to introduce the next session.
Thank you, Elizabeth. So the next session is going to be on the diagnostic of Kwashiorkor with bilateral pit edema and the stakes around it. So we'll have a qualitative study by Giulia Scarpa, who is a pediatric nurse, doing postdoctoral research with Epicentre and the Tropical Medicine Institute in Antwerp, in Belgium. She used mixed method and participatory approach in the field of maternal and child nutrition and analyzed the impact of climate change on human health. Giulia, I let you the floor.
Thank you. Thank you very much. Good afternoon, everyone. So today we are going to present this study with the title Understanding the Medical Challenges in Diagnosis and Treating Bilateral Pitting Edema in Children, a Qualitative Study. So first of all, I would like to start by introducing what bilateral pitting edema is. So bilateral pitting edema is a typical sign of Kwashiorkor, but is not exclusive to it. So it's important to make the difference between what we call nutritional edema, so the sign of Kwashiorkor. So when we see skin changes, low plasma proteins, difficult to treat, high mortality, and relatively high weight for height zeta score compared to marasmus. But about Kwashiorkor, next presentation we'll discuss more. And then what is the non-nutritional edema? So any kind of bilateral pitting edema from cardiac, renal, or hepatic condition. So it's very important to make a differential diagnosis among the two. So before conducting this qualitative study, Gian Benfarat and team conducted a quantitative study between 2017 and 2019 in two main countries, Mali and DRC, in which was shown high cases of prevalence of bilateral pitting edema with the children assessing MSF Pediatric hospitals. And the study objective of this quantitative work was to describe the children that were assessing MSF Pediatric hospital presenting with bilateral pitting edema. And the results were that half of them had acute malnutrition when measured by middle upper arm circumference, and then even more when was used the weight for height. And half of these children were anemic and hypotensive at admission, and there was high mortality, and especially in children that presented with proteinuria. But at the end of this study, health workers reported that it was very difficult to make a differential diagnosis. So it was Kwashiorkor or was another type of bilateral pitting edema. And that's why the qualitative study came. And the main rationale for doing this study is that we know a little about the diagnosis of Kwashiorkor and how to make a differential diagnosis with other bilateral pitting edemas. And there is also little qualitative work, especially working with health workers in low-income settings. And so how we can fill the gap? So we worked with local and international nurses and physicians, having a strong experience with patients presenting with bilateral pitting edema in the two countries of interest, Mali and DRC. So the study objectives were two. The first one was to understand the lived experience of health workers that were diagnosing and treating bilateral pitting edema in Rutshuru and in Kutiala. And the second objective was to identify the main challenges and strategies to improve their clinical outcomes. In terms of methods, so we used a qualitative approach with a participatory action research lens. We conducted 21 in-depth interviews and 2 focus group discussion with 25 health workers, including local and international staff. And then we analyzed these thematically using the PASS model, which you can see on the right side of this slide, in which there are 2 main domains, the social cultural context and the medical environment. And then the factors that are in this framework will be discussed during the results section. So first of all, here we start with the results. The health workers interpreted the bilateral pitting edema most of the time associated with Kwashiorkor, so the nutritional edema. In terms of gravity, they said that they perceived that bilateral pitting edema was quite high in terms of gravity due to the access barriers, for example, the high cost, the transport, and also the use of traditional treatments prior to the biomedical care, and also due to the little parental involvement during the diagnosis. So it was difficult, for example, to understand the history of the patient when he was admitted in the hospitals. So in this quote that you can see here, there is a female health worker who reported how much is important to have the family involved to understand the history of the patient, and especially the men, because they are those that at the end they are going to take the decision for the children in terms of health. In terms of diagnostic challenges, the first one that was mentioned by the health workers was that the initial assessment of bilateral pitting edema was most often done by nutrition assistants rather than physicians, and this created an overdiagnosis of Kwashiorkor without really doing a differential diagnosis. Especially in DRC, was also found that there was a limited laboratory capacity, and this hindered the diagnosis confirmation. And as you can see in this quote from a male participant, he highlighted the difficulty of making the diagnosis of Kwashiorkor and the grade of edema that each child presented. Then we have treatment challenges. So health workers reported that patients who were coming to the MSF hospital were already too sick. And because there was delays, there was misdiagnosis, and then those kind of patients often had complications such as sepsis, metabolic instability, and organ failure. And also they reported that patients said to them that there was a lot of confusion in the recommendation at the discharge of the patient. So there was, for example, a conflicting advice on the ready-to-use therapeutic food with or without home food. And this depended not just among the countries, so Mali and DRC, but also within the same team in the same countries. So the last part of our results is about the recommendation that health workers gave to us. So it came from focus group discussion with staff both from Mali and DRC, and they highlighted 4 main domains. The first one was prevention, standardization, staffing and training, and research. In terms of prevention, they said that it's very important to strengthen infant and young child feeding and also doing more community engagement to avoid the delays of children coming to the hospitals. In terms of standardization, they said that it's really needed for the diagnosis part to have unified diagnosis protocols and also history-taking templates. In terms of staffing and training, they said that they needed more skilled staff. They need also psychological support, not just for the children, but also for the family that were accompanying them. And last but not least, they talk about research, saying that Kwashiorkor is particularly under-researched, so they need to know more about the pathophysiology and having so tailored treatments. In terms of recommendation, this also because we continue to use from the beginning up to the end the participatory research approach. Then we discussed the main clinical recommendation among the research team, but also MSF advisor and operation, and we came up with the 5 main recommendations from there. So the first one is that every child that presents with a sign of malnutrition and bilateral pitting edema should start immediately nutrition treatment. The second one is the importance of ruling out other comorbidities, so to make the differential diagnosis. The third one is the importance of placing, if possible, those patients presenting with bilateral pitting edema nearby nursing station, so then there can be a vital sign monitoring every 3 hours if the context allows so. The fourth recommendation was about including community engagement and mobile clinics to sensitize patients and parents on bilateral pitting edema. And then finally, it was discussed that in any case, the care needs to be tailored to the child condition and to the context. So in conclusion, we can say that a multifactorial approach to manage the bilateral pitting edema is essential, and health worker must be the core to shape the responsive strategies. For sure, in terms of further research, there is still a lot to do in terms of understanding about Kwashiorkor, and what came directly from our research is also like the importance of doing the analysis of community and caregiver perspective to understand better the social cultural context, and so tailor a more contextually relevant intervention to prevent and treat children presenting with bilateral pitting edema. And this is going to be it was not possible to do in our work because it was a COVID time, so I had to conduct all the interviews online. It was quite intense, and we couldn't include the community and caregivers. So this study has been recently published in PLAS Global Health Journal. And just to end, I would like to thank you, all the participants that participated in our study, without whom this study would not be possible, all the MSF team in DRC and Mali, Ministry of Health, Epicentre, and the University of Leeds who contributed to this work. Thank you.
Thank you very much, Giulia. So we're trying now to include this kind of diagnostic in outreach. Usually it's done only with MUAC, and we try to integrate edema identification with that, but it's not without challenge, as Giulia say. And I think now we can go to our next presentation.
So we're sort of going backwards a little bit. We've talked about treatment, we've talked about diagnosis, and now we're going to talk a bit about the why. As many of you will know who treat malnutrition in the field, Kwashiorkor is one of our biggest challenges. And why Kwashiorkor takes place in the multi-systemic way that it does, affecting the liver, the gut, the skin, and then the edema that we see, is still something of a mystery. We see lots of it in certain contexts and not very much of it in other contexts. Is it due to nutritional deficiencies? Is it due to environmental factors? Well, for this next talk, we're going to get some insights into some of those biological processes behind Kwashiorkor, that variant of severe acute malnutrition. So Dr. Bryan Gonzales is an associate professor of human nutrition at Ghent University in Belgium and a senior scientist at Wageningen University in the Netherlands. And he is going to talk to us about all things omics.
All things omics, well, that's a big deal. Thank you very much for your generous introduction. Thank you to all of you for still being here, and especially thanks to those who are still awake. So I know it's late during the day. This is my first ever scientific day, so also thank you to Epicentre for bringing me here to Paris. I hope I pronounced that right. So, so Giulia has already introduced to us Kwashiorkor. Thank you for that, Giulia. Bilateral pitting edema being the gold standard for Kwashiorkor diagnostics. How difficult it is to identify bilateral pitting edema in comparison to other forms of edema, and especially for noting the importance of understanding the pathophysiology of Kwashiorkor to derive better treatment strategies for these children. So the remaining question still is, and the bigger question, if I can make this work, is what causes Kwashiorkor? What is the pathophysiology of Kwashiorkor? Meaning, how does Kwashiorkor develop in a child that has it during treatment? And how does that trajectory compare to children with marasmus, for example, the other type of severe acute malnutrition? So there are several hypotheses already on the etiology or the causes of Kwashiorkor. Most importantly and famously is the low protein diet. For sure, all of you have heard of that. But more recent studies have actually not been very consistent on the result of this. We have had studies that demonstrate even that giving protein is not enough to treat all children with Kwashiorkor. So there has been a lot of inconsistencies, and many of these other hypotheses that I have here on the slide have not been really supported by large-scale, consistently by large-scale epidemiological studies. So it's safe to say that Kwashiorkor until now is still what André Biand would call an enigma. So it's still very mysterious. So to demystify the enigma of Kwashiorkor, we dig deeper into biological processes. We looked at cellular processes. We use more advanced technology, laboratory technologies, and we use techniques that are used now in molecular biology. So when we say molecular biology, it really means that we're going deep into cellular processes, what is happening systemically in the body, and it starts with a gene, right? So you have a gene and it's translated to an RNA. There was a discussion a while ago about genes, so I'm sure you're very familiar with genes already by now. And when you have RNA and it's you express an RNA, then you produce proteins like albumin, CRP, AST, ALT. So these are proteins, right? So when proteins interact with each other, especially enzymes, you produce small molecules called metabolites. So metabolites like caffeine is a metabolite I'm sure all of you are very familiar with. Glucose, for example, is also a metabolite, right? So when we study molecular biology, especially systems biology, normally in the past we would do them one by one. So we study one gene at a time, or several genes at a time, or several proteins at a time, or lipids at a time. Now the technology has advanced so much that we can actually analyze many of these many of these molecules at the same time. So we can analyze now, we can sequence the entire genome rather cheaply. We can analyze hundreds of proteins, thousands of metabolites if you want. So when we do that analysis of many, many, many proteins, many metabolites, we call that omics. So when you have millions of genes, that's called genomics, proteins, proteomics. Coming here this morning, you might have seen a building here just next. It's a big building with a big logo. It's called Omics. So that's what they do. So now at least you know what they do. You can go there. That's, I know what you're doing, right? So that's Omics, my dear friends. But the problem with analyzing many, many, many proteins, many genes at the same time becomes a statistical problem. So normally when we do studies, we have many observations, many participants, many patients, and a few variables, right? 1,000 children, 20 outcomes or 20 variables. Now, in genomics or in omics studies, we study thousands of variables, and we only have a few participants. So in this study, for example, we have 180 participants, and we have over 4,000 variables. So that becomes a statistical problem, and normal statistical platforms and systems don't work anymore, and that's why we dig into the world of big data, machine learning, systems biology, bioinformatics, and data dimension reduction techniques, right? So when we say data dimension reduction, it means we want to understand many, many, many proteins using a few number of variables. So how do we do that? Imagine that each of these dots is a protein or a metabolite. The first thing we do is to cluster these metabolites into tightly correlated metabolites, and we call them latent variables. So if you're familiar with principal components analysis, it's very similar. What we used here is a high dimensional factor analysis. So we basically represented a cluster of proteins or metabolites using a single value, and it's called LV, latent variables. And we use these latent variables to represent the entire cluster, which empirically actually represents different pathways in the body. So these LVs represent either immunity or inflammation or bone growth or whatever. So empirically that happens. So what we can do then is use these LVs in our statistics. So this is how we graphically represent our data in omics studies. We have on the x-axis the odds ratio, y-axis we have the negative log of the p-value. Don't ask me why we complicate things like that. And all these latent variables that pass the mark are the ones that are significant. So anything above that line of 0.05 are the significant pathways. So I would like to emphasize that we're making inferences here at the pathway level, not at single proteins. And that saves us alpha error, because as you know, the more t-tests you do, the more false positives you get. So this is basically the strategy that we used in this study. The study I am referring to is a study, and thanks to MSF Innovation Fund, it's the study understanding the etiology and pathophysiology of Kwashiorkor that we performed. This was me when I was young and beautiful in Niger. I say that to people, and they say, "Oh, don't worry, Bryan, you're still young." Not beautiful anymore, apparently. So the study design is that, so we did this study in Madarunfa, Niger. We recruited children with Kwashiorkor, 20 with +1 bilateral pitting edema, 20 with +2, 20 with +3. And we recruited children as well with marasmus and non-malnourished children. And we matched these children on their age group, on sex, and emergency triage score, which is a proxy for their clinical severity. We included children that are 6 to 59 years of months of age, and that they are diagnosed with SAM or they are non-malnourished. They need to be newly admitted, meaning they cannot be transferred from inpatient to ambulatory and vice versa, and they need to be direct admissions. We excluded children that are not able to give 2 ml of blood, because of course we need to analyze their blood, and those that cannot do that are the ones that are more severe, so we had to make sure we prioritize their safety. But because we also analyze a lot of metabolites, we wanted to make sure that we get blood samples from these children before they get any antibiotics or any anti-malaria drug or whatever have you. But most importantly, we tried our very best to exclude children who are who have bilateral pitting edema or edema of non-nutritional reasons. So we have a urine test, and we excluded those that have blood in their urine and have protein in their urine. So we hopefully made sure that all the Kwashiorkor cases we have are really Kwashiorkor. So just to show you the demographic that we have, so we have age match, sex match, and ETAT score matched children. Majority of our children were obtained from the green zone, so the non-emergency cases, and half of the children were hospitalized at baseline, and half of them we recruited from ambulatory care. Yes. So this is a design. We collected blood samples from children when they were admitted to the hospital or when they arrived at the ambulatory care, when they exited the inpatient treatment, and after nutritional rehabilitation, meaning they are recovered nutritionally based on WHO guidelines for the children with SAM. And for the non-malnourished children, we have them at baseline and when they exited the hospital for whatever treatment they went there for, or at the outpatient when they are matched with a child with outpatient. And we performed all these omics technologies that by now I'm sure you are very knowledgeable about. Good. So I just have this figure here to remind you we're doing pathway level analyses. So how do we judge which pathways are related to Kwashiorkor? So these pathways should be different in Kwashiorkor compared to non-Kwashiorkor cases. The pathway should be associated with a degree of edema severity. And if it's high at baseline, it should go down after nutritional rehabilitation and vice versa. So very strict criteria for us to understand which are the pathways related and specific to Kwashiorkor. So we performed all these omics studies that for sure you are now experts on. So in the interest of time, I will only discuss the ones that passed the three criteria that we mentioned. So for the proteomics, again, we analyzed almost 500 proteins at the same time that resulted to 9 protein clusters. LV7, so latent variable 7 for protein, is different in Kwashiorkor compared to the others. It is associated with edema severity. It was high at baseline and it went down after nutritional rehabilitation. Now we understand what is PLV7, so we looked at which proteins are in this cluster, and it's called lumican, gyalsuline, and tetranectin. And these proteins are actually extracellular matrix. So these are the proteins that are forming your collagen layer, the ones that are in the interstitium. They are the ones that build your lymph nodes, for example. And here below, you see the different organs in the body. If you see a black dot, it means that these 3 proteins are there. So it means that these proteins are found systemically in the body. But again, they are collagen. So if they would have been found in the blood, like what we have, it means they broke down. And breakdown of these extracellular matrix are typical signs of inflammation in a child. I just want to highlight that we did a separate study. This was in Niger, but previous to this, we did a similar study in Kenya and Malawi, and we found the same protein signature of a breakdown of extracellular matrix proteins. Now, looking at different lipids, there's also one latent variable that is associated and specific to Kwashiorkor, and that's LLV5. It is lower in Kwashiorkor compared to the rest. It is associated with edema severity, and it's lower at baseline, and it increased after treatment. And looking at what is LLV5, these are sphingolipids. So these are the lipids that cover the cell membranes. They are also the ones that cover the nerve cells, for example, and they are also inflammatory modulators. So putting that together, it appears that extracellular matrix and low sphingolipids are related to bilateral pitting edema, and I put here that dietary deficiency could be part of the pathophysiology of Kwashiorkor, but it's not enough. And there is, we have observations to suggest that inflammation could be part also of the pathophysiology of Kwashiorkor. So our take-home message is that Kwashiorkor, according to our study, is associated with extracellular matrix remodeling and sphingolipid metabolism, which may indicate an inflammatory syndrome. So if there is inflammation in Kwashiorkor, how do we move forward with that? Then maybe giving them protein is not enough. Maybe we can explore giving them anti-inflammatory treatment as well. I'm not saying that this is the silver bullet here, or the gold bullet or whatever bullet have you. But it's worth exploring, right? So maybe adding more anti-inflammatory or whatever agents in RUTF or F75, or giving everyone zinc or selenium or whatever. We can also use these markers to closely monitor the inflammation of children, because a lot of the children that are discharged from the hospital die within the first 6 months when they come home, and maybe this has something to do with that. Or if you find it useful to have an early diagnostic test for Kwashiorkor, then these are the proteins and lipids that might be good candidates for that. And with that, I would, of course, like to thank all our participants, all the parents, the children that were involved. I would like to thank MSF Innovation Fund for the support, MSF Niger, who were very dedicated despite all the logistical nightmares that I introduced them to. And yeah, again, for all of you, thank you very much.
Thank you so much, Bryan, for that really entertaining talk and for explaining it so clearly to us, quite a complicated subject. I find the discussion around inflammation absolutely fascinating. I know that there's some work coming out around iron metabolism and inflammation and its effects on hepcidin. And I'm going to take advantage when we open the Q&As now of asking the first question about where you think that inflammation potentially is coming from. Is there anything that can source it? Is it helminth infections? Is it teeth? Is it skin?
That's a very interesting question. It's not covered in the scope of our study, so that's hopefully something we can still investigate further. But there is a lot of environmental issue and one thing. You know, the children, of course, that are subjected to severe acute malnutrition are in areas where there could be a wash problem, sanitation issues, of course. But there could also be a genetic component to it. So we have some indications that a child, for example, would come in our treatment facility with Kwashiorkor, and then we treat them, and then they relapse. They always come back with Kwashiorkor. And those that have marasmus also come back at the same time. We have colleagues in Jamaica that compare the birth rates of children that eventually develop Kwashiorkor and marasmus, and they found that there is a difference in their birth rate, so birth weight. So there could be a genetic component to it. It's possible that if we malnourish all of you, some of you would have the propensity to develop quash, and some of you probably not. But again, that's still a big research that hopefully we can untangle in the future.
Thank you.
That was
Yep. Thank you. So this is Kate Alberti from WHO Global Task Force on Cholera Control, and this is more a comment than a question about the GastroSam study. And it's more just to say thank you. Working in the cholera world, we get a lot of children. This was raised by one of our colleagues in DRC during the cholera session. You get children with severe acute malnutrition and cholera, and we have been severely limited in the way that we can rehydrate. Those on the cholera side of the equation are always concerned about the fluid loss and the rate of fluid loss. And on the other side, there has always been constraints, I would say, to be polite, about how quickly we can rehydrate those children because of the safety concerns around cardiac function, amongst others. So I just want to say, I think this is, I'm just really pleased to see the results of this. It's going to be another piece of the puzzle. I think the question about nasogastric tubes was also extremely interesting. It may not have been a primary outcome, obviously, but especially when you're working, the simpler protocols can be, especially, I just came back from Angola. You've got treatment centers. We had probably malnourished children, more chronic malnutrition, but still we had more patients than beds. These were big structures with overwhelmed staff. The simpler the protocols, the better. And what you are contributing to is a simplification and a more similar, probably the same protocol for everyone, which is extremely helpful for overwhelmed staff. Clearly what you showed is that the better monitoring has an potentially as big an impact on outcome as anything else. But I think the nasogastric tube question is also really interesting, because what we realize is that staff don't always have experience with nasogastric tubes. And if we can they've got more experience actually with IVs than nasogastric tubes. And if we can, you know, that's another piece of the puzzle. So it's more a comment than something else, but just to say what that piece of work will also contribute, I think, greatly to the treatment of cholera in children with severe acute malnutrition. So thank you very much for giving us another piece of the puzzle.
Thanks for saying that. I'm also glad that you're also from the WHO, so I hope that this can open a discussion on that, because this was the big concern about the safety, and we're glad that we're able to have more insight into what is safe for these children. And I think hopefully with this understanding, we can push for us to start discussions about how we can simplify, you said, all those protocols.
So Kemi, I've got another question for you from online. So this is from Manu Burbain, who is our nutritional advisor at MSF France. And I'm going to read it out word for word so I get it correct. The new MSF guideline, pediatric guideline, recommends the opposite. Children in hypovolemic shock to receive hypotonic infusion glucose ringers 10 mils per kilo per hour, although the previous 2017 was reasonably recommending 15 mils per kilo per hour of ringer. Urgent amendum has to be done while at the time of this press, hypovolemic shocks are no more not treated in settings where the new guideline has been implemented. So I wondered if you wanted to comment firstly on the hypotonic question and secondly on moving forwards with the pediatric guidelines.
Thanks. I won't touch too much on what we're going to do for the pediatric guidelines as much here, but I'll highlight a few points because this is an interesting question. So first of all, it's not hypotonic solution. If you look at the manufacturer, D5 Ringer's lactate is hypertonic, so we can simplify and get rid of that part of the argument. But the second question about what we're giving for fluids, want to highlight from this study that what the liberal arm had Plan C, the standard WHO Plan C, which is over 5 hours for younger children, and 8 hours there was a slow arm that was over 8 hours. If you look at the guidelines that we have right now, if you continue to assess and treat, you can give 20 mils per kg every 2 hours until you finish treatment, which is very similar to the slow arm. In the slow arm of this study, we didn't give a bolus to the children even if they had shock. There was no difference in mortality. So we can clearly say that it's not a bolus or giving fluids faster that saved the children. It was that we can give IV fluids safely, and even with shock, in the slow arm, where we did not bolus them, there was no increased mortality.
Thank you. We have a question from Serge Enougui for Giulia. So in terms of community engagement, in order to try to have children come earlier to the hospital, what about working with a tradi practitioner? Would that be an added value, or is it something that you tackle in your study?
Thanks so much for the question. Yes, actually, we discussed that with some of the participants, and they were, it's always complex to deal with traditional medicine versus the biomedical care. So, from what we found also, in previous studies, again, it is very controversial, but the role of a traditional practitioner can actually be used to connect the community with the more biomedical stuff. And this can actually be super helpful because they are those that know more the context and they understand better the type of issues that are in the community. And so they are those with whom we can actually discuss what can be contextually relevant. So, yeah, thank you.
Two quick questions here. First, for the GastroSam study, the levels of hyponatremia were quite high, and that was very fascinating. Can you say anything about the levels of hypokalemia that you found in the study? And then I'll go to the...
It wasn't as significant. There's a bigger table with, hopefully with article next week, there will be more details, but there weren't as many cases of hypokalemia and severe hypokalemia as compared to hyponatremia. And we didn't see as much difference in the correction as we did with the sodium. Those were the main findings we had with that.
Another quick question for the first research, if it's possible, regarding the nurse monitoring in the two groups. Did you have different nurse monitoring for taking the vital signs and so on, or it was with the same frequency?
The frequency was dictated by the protocol in terms of we had certain things we had to do at certain times in terms of collection of labs and monitoring certain vital sign moments. So it was based on the protocol for any child who was randomized to any arm. So it would be different from a standard monitoring, yes.
Okay, thank you, Bryan, for your very interesting presentation and for teaching us a lot about the omics. My question is, this severe acute malnutrition occurs mostly in the very poor populations, if I'm right. There's metabolomics that you're telling us about, proteomics, lipidomics, and you're concluding by telling us we could use it probably for screening for severe acute malnutrition. Did I get that right? I'm just wondering, what is the cost of this omics vis-a-vis the context? And secondly, what kind of infrastructure would we need to use these omics for screening for severe acute malnutrition? And how specific or sensitive would the omics be, knowing that the proteomics, metabolomics are really not very sensitive? I mean, they're not specific to any disease manifestation. How would you recommend that for screening? Thank you.
Well, thank you very much. Cost, unlike me, these things are not cheap. But it's to say that there are activities even within MSF to try to look at early detection. The omics that we have really here is to understand the pathophysiology. It's not to do omics so that you can do an early diagnostic. By using omics, we already identified 2 proteins. So we can just move forward with those 2 proteins. We don't need to do the full omics to do it on a diagnostic scale, for example. There are surprisingly a lot of facilities already in Africa building omics facilities. So it is starting there, but it's still it's not something I would do on a survey, for example. Yeah. Thanks for the question.
I think in the interest of time, we probably will bring the session to a close. I'm so sorry, but there will be opportunity to ask more questions to our panel afterwards. I'd like to thank the panel for presenting. It is a sad world currently in the nutrition world. You know, every day there is more news of a spiraling nutritional crisis or slashed aid budgets or disrupted supply chains. And so to sit on the stage and to hear insights and good news about improvements in treatment and diagnosis and cause, you know, understanding why and what's going on has been a bit of good news in the world of nutrition. So thank you very much to our panel for coming and presenting, and thank you very much to the audience for your questions.